Yeah, great. Well, thank you so much. I know Shivani's going to come on here as well on camera, and we'll go into the Q&A. So, Dustin, if you want to share your screen or share your camera again, we'll do this live. Um, Thank you both for two really amazing presentations. You had a lot of great practical tips in there that I think will be very useful for those who are not only evaluating to implement Bayesian dosing, but even those who have already implemented it. We have just a few minutes left for questions, and I would say I got when I look at the questions, probably half of them were related to when you obtain levels, how many levels you obtain, when might you obtain, one level versus two levels, and how do you do random levels? So maybe just each of you take a minute or two and just reiterate sort of your process around when you take levels and how frequently you take levels. So Shivani, if you could start, that'd be great.
Yeah. So we decided how we were going to handle levels based on the model that we were using because we have multiple models available to us. So for our one compartment model, our patients get a loading dose, we start maintenance dose, and then we get a random level in the morning with AM labs. And if the level based on the level, if there's no dosing recommendation changes required, we don't get another level for 5 days unless Dose Me, when we run the model every day, recommends something different. For our two compartment model, so those are the patients that are on vasopressor therapy, for some reason have altered volume of distribution or just have unstable renal function where we're worried about clearance. What we do is we get two levels for those patients. We do a level with AM labs just to make it easy for the nursing staff, and then we do a second level somewhere around 10 to 11 a.m. so that both levels are back for day shift to be able to run the model once both levels are back. And that allows us to look at actual vancomycin clearance for that patient with a two compartment model and make dosing recommendations based on that.
Great. And Dustin?
Yeah, awesome. So for us, looking at monitoring, we utilize troughs, and we stuck with troughs to monitor and derive AUC. So we do a single trough for the majority of our patients, and we only purchase a single one compartment model. So we don't have the two compartment model as Shivani does at her institution. So one of the things, if we saw any situation that arose where volume distribution is in question, maybe it's fluctuant, and we wanted to see if make sure the model's capturing that accurately, we might add a peak concentration at that standpoint, or in the most severe infections, we might add a peak to make sure we're getting the most accurate AUC estimate within our institution. But it's still trough-based monitoring, and we do that typically between every 3 and 5 days, and it's up to the pharmacist's discretion on how often that's monitored. Depends on clinical situation, and then of course patient stability with renal function and the dose me recommendations now.
Okay, great. Thanks. That was really helpful. This question is for Dustin. Do you have any suggestions, Dustin, on how an institution might structure their medication use evaluation or MUE to help identify AKI and associated cost savings?
Yeah, so when you're structuring those MUEs, it's really tempting to go with a very sensitive marker or looking at some of the definitions set forth by KDIGO, AKIN, things of that nature. And that's something we did at our institution. We used a serum creatinine measure of 0.3 or greater, an increase to that extent, or a 1.5 times baseline. However, most of the financial data out there is actually going to go back to the more technical definition of vancomycin-associated nephrotoxicity. So I think the biggest thing for you to structure your MUE is to go find a financial paper that you really trust, you really have confidence in, see how they defined AKI, and then model your MUE definitions of AKI behind that paper. That way, the results you find are directly translatable with the financial savings.
Oh, that's great suggestion. Another question that we got today, and this one comes up a lot, and I was wondering maybe Shivani, if you could comment, and then Dustin, are you applying AUC dosing to non-Staph aureus infections? And
So
if
we
so, what is kind of your general target range?
We are. So we are doing it for any vancomycin therapy across the board. The vast majority of them target Staph aureus and specifically MRSA, but the reason that we felt comfortable using it for non-Staph aureus infections is there was a few small papers on enterococcus where they showed that achieving an AUC of greater than 400 improved 30-day all-cause mortality in enterococcal infections. So that was our surrogate endpoint for enterococcus and other strep species. And then there's really a lack of data for coag negative staph, but we've just really looked at breakpoints and making sure that AUCs and the patient's clinically improving, right? So clearance of repeat blood cultures and severe infections like bacteremia. If we've had persistent bacteremia, we've either pushed the AUC target or we've changed to alternative, but it's been clinically based, really, not AUC based for those patients.
Okay.
Yeah, awesome. And like Shivani said, there's not a lot of great data out there outside of Staph aureus, specifically MRSA. But we felt confident in switching, and we still utilize AUC dosing. We still target that 400 to 600 range in all of our vancomycin patients because we feel pretty confident about the efficacy line and as well as the safety markers there in that window. The issue we run into is, I mean, we've always dosed those patients based off of trough, and troughs were always a surrogate for AUC. So we felt confident rolling out AUC there based on the clinical data and the clinical experience we've had in the past. But there's definitely a need for more research in that area.
Okay, great. Well, that takes us to the top of the hour. We have a number of other questions that we didn't get a chance to answer today, and that often happens, especially with this many people on the webinar. So what we'll do is we'll get those answered and follow up with the participants, and also send out an FAQ after the webinar when we share a copy of the slides. So we'll definitely get a chance to answer those questions for you. And thanks to everyone who submitted those. So with that, we're going to conclude. I would love to again thank Dr. Patel and Dr. Orvin for two amazing presentations. And thank you everybody for joining us today, and hope you have a great rest of the day. Bye.